Contrary to what we believed, estrogen receptors actually start upregulating during perimenopause and menopause. Estrogen receptors are extremely highly concentrated in regions of the brain that are associated with diseases like Alzheimer's disease. And this upregulation of estrogen receptors is almost like the body's way of saying, hey, I don't have enough estrogen floating around in my blood. Let me upregulate to try to capture as much of that floating estrogen that exists in my body to try to absorb it and use it for important processes. So that, I think, is really fascinating. Like, it suggests that the brain wants more estrogen.
Dr. Niotis, I'm so grateful we were able to carve time out of two very busy schedules to make this discussion come to fruition.
Cynthia, thank you so much for having me today. I'm really excited to share all I know about brain health.
Yeah. So I think many women notice changes in cognition and brain fog or even memory changes as early as perimenopause. And they immediately think that they're dealing with dementia or an increased risk of Alzheimer's. From a neurologist's perspective, what's actually happening in our brains as we're navigating this perimenopause to menopause transition?
It can be very difficult for people, even clinicians, neurologists that are trained to really differentiate what is perimenopausal, menopausal cognitive changes, age-related cognitive changes, and then what could be an early sign of something like Alzheimer's disease. There's a lot of significant overlap. For example, language skills can be affected, word finding difficulty, just having a harder time finding that word, it's at the tip of your tongue. Those could be signs of perimenopause. Those could be signs of age-related cognitive decline. And in some cases, they can be an early sign of Alzheimer's disease. So it can be really tricky. To answer your question about specifically what's happening to women as they go through perimenopause and menopause and why that may impact cognition, well, a lot of it has to do with hormone shifts. And we know that there's really rapid fluctuations in hormones during the perimenopausal period, where hormones, specifically estradiol, can be very high and then they can drop off pretty quickly. And the brain is very sensitive to these abrupt changes. So some of these cognitive changes that women are experiencing are related to that. But then again, it's also important to recognize a lot of these vasomotor symptoms that happen during perimenopause, like changes to sleep, changes to mood, all of those things can also indirectly impact cognition. So it's really hard to suss out exactly what the immediate cause of someone's cognitive changes are, since there's so many things happening at one time.
Yeah, and it makes so much sense. I think that there's so much concern over the evolving nature and information that's available to women, between social media and, hearing from experts on podcasts about what they can be doing. When you're doing an intake on a new patient, and let's say they're 45 or 50 years old and they come to you with concerns around this, what are some of the initial first steps that you will do in an evaluation before you are even doing diagnostic testing, if that's even part of the kind of treatment modality?
It's really important to take a thorough history. That often for me starts with a family history, especially related to dementia and other neurodegenerative history in first degree relatives. The age of onset of their symptoms is also very important because over generations, that age of onset is relatively consistent. It's not a perfect science, but if, for example, your mother started to experience cognitive symptoms in her early 70s, it gives us a very good estimate about when someone might be experiencing cognitive symptoms related to a neurodegenerative disease. So if someone's coming in at 45 with cognitive changes and their family member wasn't having these changes until they were 70, it could be just a little clue that there's something else contributing. And then doing a deep dive in terms of what their lifestyle factors are. How are they sleeping? How are they managing stress? How are they managing their vascular risk factors? all of those things can contribute to cognitive function. And then, of course, really doing a deep dive in terms of understanding the nature of their cognitive symptoms. Are they noticing it? Are other people in their lives noticing it and pointing it out? And really specifically, what are they experiencing? Is it, as I mentioned earlier, word finding? Is it feeling scattered or brain fog? Are they finding themselves making lists more frequently? These are just kind of some examples that I hear frequently in our practice.
Yeah, because I think that there are little blips in our memory, as an example, that are a byproduct of like jet lag or not getting enough sleep or just being stressed while traveling. Like I know for myself personally, if I'm not getting enough sleep sequentially over several nights or have quite a bit of jet lag, I will find that for me personally, I know that my articulation and my ability to speak and feel comfortable and confident is definitely impacted more so now in menopause than I've ever felt. But if I'm sleeping well and my nutrition's on point, I'm not dealing with overt stress, I don't usually have those symptoms. And so I think it's reassuring for people to know that you can have like a transient blip. Like I jokingly tell people, I've never been good with names my entire life. I always say it is not menopause brain. It is something I've experienced since I was a teenager, but that isn't a concern. But if I suddenly feel like I'm struggling a great deal with word finding, or if I'm doing podcasts is a great way to have a sense of how well, you're performing cognitively from the perspective. So you do this very extensive history and get a lot of information in terms of, I know back in my cardiology days, we would use the mini mental just as a like kind of a coarse way of getting an assessment. But I know that as a neurologist, you're looking a little bit more deeply. Are there specific tools that you use in your practice to get a sense of their baseline cognitive status at a very beginning stages?
Definitely. So as you mentioned, the mini mental status exam and the MOCA is another one, Montreal Cognitive Assessment, are tools that are frequently used for dementia screening. They give us a sense of someone's global cognitive function, and they do test various cognitive domains. In my experience, these tests are not that sensitive to detect the earliest signs of cognitive changes, and they are really insensitive in people who have an extremely high cognitive reserve or a high baseline intellect. Highly educated people who have achieved a lot in their careers and professional lives can mask signs of cognitive decline very easily. And even if they are experiencing a change, they could do completely normally on one of these assessments. So they're rather insensitive tools in the earliest stages. So we have put together a more extensive cognitive battery for our practice where we look at all different cognitive domains because each cognitive domain really maps to a different region of the brain. So, for example, when we're thinking about memory, one of the first cognitive domains you have to test is attention. And that's often the reason why most people can't remember something because they are having information overload and are so scattered. And if you can't spend time paying attention and focusing on the information in front of you, you will never ever remember it. So it's really important to look at all different cognitive domains because they really do impact your brain function in various ways that make the picture more clear and help us really sort out what could be a neurodegenerative process and what can be something that's more lifestyle related or related to other external factors, whether they're medical or non medical.
I think that's really helpful because I think for so many of us, especially I'm in the sandwich generation, so I have older children, aging parents, and you feel like you're pulled in many directions. And so I would imagine your middle-aged patients probably express the same concerns that they feel scattered or they can't pay attention because they're pulled in so many directions. When do you get to a point where you're looking at a PET scan, an MRI, CAT scan, when you're doing, deeper observations of brain health beyond these kind of these targeted screening modalities?
I should say about the cognitive test that it is nobody's favorite assessment. Almost everyone universally dreads taking this test. Um, and that also adds a flavor to someone's performance, because if there's a lot of anxiety when taking the test, you're just not going to show your true colors in terms of your cognitive function. So cognitive testing is great, really important, but as you kind of alluded to, it is a limited tool. Um, in general, a brain MRI can be wildly helpful for just healthy people. It's not routinely recommended in any sort of medical practice, and you're not going to walk to your primary care doctor and say, I would love a brain MRI. But from my perspective, I gain a lot of information from looking at someone's brain MRI, especially when they're middle aged, young, 20s, 30s, 40s, 50s. It really tells us about someone's baseline brain anatomy, because when we're looking for subtle changes related to neurodegenerative diseases, they can be very, very hard to detect on something like an MRI unless you have more longitudinal data. So establishing that baseline is really useful for our practice. And then it really does tell you about someone's vascular risk, because we can see evidence of white matter hyperintensities on brain imaging, which is a complicated medical way of saying damage to the small blood vessels or the protective coating that surrounds our brain cells that help send signals to various parts of the brain very rapidly. Um, Often, when we see these white matter changes, they're related to vascular risk factors. Things like high cholesterol, high blood pressure, insulin resistance, but they also have been linked to more severe vasomotor symptoms in menopause. They can be associated with gum inflammation. They are associated with head injuries and migraines, and all of these things really shape our understanding of someone's risk, because we do understand that while we thought these were benign findings once upon a time, and most reports when you get an MRI will brush these things off as non-specific ditzels, but the more you have of these lesions, the higher your risk is later in life of cognitive decline. So they do matter. A couple of them are not going to impact your cognition, but over time, the more and more you have, the more substantial your risk is.
It's so interesting because I think there's very much this Goldilocks effect, if you will, about cholesterol. Like, obviously, Dr. Tom Dayspring, who's a mutual friend, has been a guest on the podcast. I think we have 9 published episodes. So we've had many, many conversations. And I know this is an area of interest of yours as well. There's this Goldilocks effect about cholesterol. It's so important for not just transmission of information, but also the health of the cell. From your perspective, when you're looking at lab work for patients, when you're helping kind of risk stratify, and you've kind of identified that there's definitely brain changes that can identify people who might be at greater risk for having vascular issues later in life, what are some of the common labs you're looking at that can help point you in the right direction for brain health concerns? Obviously, insulin resistance would be probably top of the list, but what are some of the other things you're looking at with lab work to get a sense for how healthy someone's brain may or may not be?
Right. Great question. Definitely, as you said, looking for evidence of insulin resistance is important to us. We look at hemoglobin A1C, but as I'm sure many listeners and you are familiar, it's an imperfect measure. Sometimes people can have early signs of insulin resistance and it's not really showing up in their hemoglobin A1C yet. So, looking at other things like fasting glucose and fasting insulin levels can be really helpful. And as our dear friend Dr. Dayspring has taught me, and what is my latest infatuation, is VLDL, which is a type of remnant cholesterol particle, um, a remnant LDL cholesterol particle that actually becomes high in metabolic syndrome or in early signs of insulin resistance. So, something that most people wouldn't really necessarily look at when they're thinking about, oh, what is my metabolic health? You can actually get some clue in someone's lipid panel. And then, of course, triglycerides will tell us about someone's metabolic health collectively, what their diet looks like, how much refined carbohydrates, breads, pastas, sugars are they eating. Those things, of course, negatively impact brain health. Looking at cholesterol numbers are also really important, and specifically when we're thinking about white matter changes in the brain, looking at someone's ApoB. And heart health in this case really is brain health. Um, it has taken, the cardiology community and the lipidology community so long to come to the consensus that ApoB is actually a better marker of the atherogenic potential of someone's bad cholesterol particles. So you can imagine that in the neurology literature, we are really, really far behind. So we don't actually have a lot of literature published on ApoB levels and long-term brain health. There's some, but it's not as vigorous as it is for cardiovascular disease. But I think we could probably both agree that in general, what's good for the heart is good for the brain. So I expect over time that we see this shift also in neurology. We're just a little bit behind the ball here.
Well, and I love that you think so thoughtfully about this because I know that sometimes traditional allopathic medicine can be very siloed. Like what happens in the brain stays in the brain, doesn't deal with anything else in the body. And we know that's certainly not the case. And I love that you are so conscientious about apolipoprotein B, something we have talked about a lot on the podcast. And in terms of let's think about lifestyle things that we know can impact brain health quite substantially. You kind of touched on carbohydrates, ultra processed foods. Let's talk about alcohol because I think this is now emerging that we know that no amount of alcohol per se is safe. But I would imagine being privy to looking at MRIs and other types of screening modalities, you get to see the long term effects for those that drink excessively and persistently.
Yeah, so excessive alcohol use is a recognized modifiable risk factor for dementia. What defines excessive alcohol use? In general, it's referring to more than one drink per day for women and more than two drinks per day for men, or I think it's more than, and don't quote me, I should double check, but more than five drinks in a sitting. Um, so, you know, in that is pretty, if you think about it, like most people are saying like, oh well, like even one drink a day is really going to hurt the brain. And yes, alcohol is neurotoxic, but we actually don't have a lot of evidence to support that one drink once a week or two drinks once a week is really doing any long-term damage for the brain. I will say that I've seen firsthand the neurological consequences of excessive alcohol use in terms of what it does to the peripheral nervous system, to your ability to feel the ground beneath you, to your walking, but also just in terms of global brain volume. It shrinks people's brains, and you can clearly see the difference between someone who doesn't drink and someone who drinks excessively.
Do you see that alcohol, other than shrinking the brain matter, are there specific areas of the brain that are most impacted by chronic overuse? We're not talking about having one drink a week. We're talking about the people that drink heavily and excessively.
The area of the brain that is most sensitive to alcohol toxicity, there's many areas, but the one that I classically think of is the cerebellum. That's the part of the brain that's underneath our big brain. It's in the back of the brain, and it's responsible for accuracy, balance, coordination. Um, Anyone who has been intoxicated will understand what the function of the cerebellum is, because if you are intoxicated, you are staggering. You can't walk. That's because it's a cerebellar toxin. Your speech is slurred. You have vertigo or room spinning sensation, all of the, and feel very imbalanced. All of those things are really directly related to alcohol's acute effects on the cerebellum. And then long term, we see the cerebellum really shrink and people develop these very wide based walking patterns just to kind of get better stability.
I find it so interesting. I have a family member who's now deceased, but when he had a subdural hematoma, which is a head bleed for listeners, I remember, talking to the trauma surgeon, the neurosurgeon, and saying, I want to make sure that you understand that this family member has a longstanding history of alcohol use. And he said, I appreciate you sharing that, but I already knew that. And then he was actually showing my brother and I on the scan, like what they could see and explain, like, I'm so grateful you shared that with me. but there's specific things that we look for that we can tell pretty quickly and pretty readily if someone, not just a occasional drinker, but like a heavy long-term drinker, what their brain matter will look like. Do you feel like the conversation around hormones as it pertains to the fluctuations? I always think about estradiol predominantly, but we know that progesterone and testosterone also have a role in brain health. I think estrogen gets framed as this bikini medicine. It's just a reproductive hormone. But talk to us about how estradiol in particular is so helpful and beneficial to our brains, and how that, the changes and alterations in estradiol in perimenopause and in menopause can influence the way that we perceive the world and just what's happening physiologically in the brain.
Yeah. Well, I think you said it well when you said that kind of estrogen is the bikini. It really does get all of the publicity and attention. And it's true, that's where most of the research is in. But I do want to give a shout out to progesterone because while we have always viewed it as just something that protects the uterus against excessive or thickening of the lining, it probably also does have neurological consequences. Women who take progesterone report feeling calmer, um, they report better sleep. So, that in itself really is suggestive that it is doing something for the brain. Whether or not that progesterone levels are tied to risk for dementia later in life, I don't know, but my guess would be probably yes. So in terms of estrogen, so this is really where most of the research in the space has been. And a lot of this research comes from a colleague of mine, Dr. Lisa Mosconi, at the Alzheimer's Prevention Clinic, in the Women's Brain Health Initiative at Weill Cornell. So she actually looked at estrogen receptors in the brain and how estrogen receptor density can change during the perimenopausal and menopausal transition, and found that, contrary to what we believed, estrogen receptors actually start upregulating during perimenopause and menopause. Estrogen receptors are extremely highly concentrated in regions of the brain that are associated with diseases like Alzheimer's disease. And this upregulation of estrogen receptors is almost like the body's way of saying, hey, I don't have enough estrogen floating around in my blood. Let me upregulate to try to capture as much of that floating estrogen that exists in my body to try to absorb it and use it for important processes. So that I think is really fascinating. Like it suggests that the brain wants more estrogen and it's doing what it can in terms of upregulating these receptors to try to hold on to the remaining bits of estrogen that there are. There have been, there's a lot of, I should say, the space of using hormones during perimenopause and the science about using hormones in the perimenopausal period for specifically cognition and long-term Alzheimer's dementia risk is really, the science is really not settled. There have been randomized clinical trials that show, if there is a risk reduction benefit in using hormones, it's you'd have to treat a lot of women to get that benefit. That said, there's a lot of faulties in the way that these studies have been designed in terms of identifying the right women that might benefit from it, the right timing of using these medications, and the right formulation. We, haven't been using bioidentical hormones traditionally in a lot of this research, and bioidentical hormones may do different things to the brain. So there's a lot to be still understood, but I think that over time it will prove to be that at the right time in the right woman, using hormones in a really strategic way can be beneficial.
That's so helpful. And I've had the honor of interviewing Lisa on the podcast, and I'm so grateful for the work that she's doing and, greater awareness that's coming to these kinds of conversations. Do you feel like you're, obviously as one provider at a big institution, do you feel like the bulk of the patients you see that come into you with taking hormones, like let's say whether it's bioidentical or otherwise, do you see benefits beyond just brain health in terms of looking at it from the perspective of, confidence? One of the things that, let me just back up and say that a lot of my patients will say, I just feel so much more confident about the fact that this decision for me is the right one, because I know research is evolving, but I feel like, bone protection, potential cardiovascular risk reduction. We know the heart, as you said, astutely stated, the heart and the brain are so interrelated. Do you feel like perhaps your experience clinically is that women that are coming in, maybe starting HRT in their 40s and 50s, maybe they're feeling a bit more confident about the potential that long term that may protect brain health vis-a-vis the use of these replacement hormones?
Affect and mindset are huge. So I have no doubts that that's true. I also will say that while the data published on this is rather mixed, a lot of women report improvement in certain cognitive domains once they start hormones, specifically feeling less brain fog, more attention, improved concentration, improved ability to process information. And I think that goes a long way in terms of how they're feeling day to day.
Yeah, and that certainly plays a role in how we perceive ourselves. And I've always heard the adage that our brains in our 60s, 70s, beyond are in middle age. Do you agree with that statement? And is that something you really encourage your patients, maybe who aren't as metabolically healthy as you would like them to be considering when they're thinking long term about brain health?
I mean, our brains are made in childhood, to be honest. Everything that happened to us in childhood does shape our long term brain health. We can't go back and change if we had a learning disability that led us to be more vulnerable or susceptible to neurodegenerative diseases. We can't go back and change that. So, in midlife, early adulthood, and in midlife, that's when we can address a lot of these modifiable risk factors that we know can lead to poor cognitive outcomes and poor neurological outcomes later. So, yes, thinking about it as soon as you can, as early as you can, does matter.
What are some of the most important risk factors for neurocognitive degeneration? If someone's listening, some of them are modifiable, I'm sure some of them are non modifiable, but what are kind of the big core ones that you really like to address with your patients?
So, if you look at the 2024 Lancet Commission report on dementia prevention, intervention, and care, it lists 14 modifiable risk factors. At the top of the list, in terms of how much of the population that is affected by dementia could we attribute to these particular risk factors, the top of the list, LDL cholesterol, so ApoB, and then hearing loss. Those two actually seem to be the most globally impactful in terms of lowering risk for Alzheimer's disease and other forms of dementia. So those are big modifiable ones to think about. Hearing loss is so under recognized, and it really is a shame because Medicare doesn't pay for hearing aids, and hearing aids reduce the risk for dementia. So if you have hearing loss and you use hearing aids, that risk essentially is cut in half. So it makes such a big deal. And hopefully, over time, more and more evidence will come out and these devices will be covered by insurance. But right now, they're not. I still really advocate for protecting your hearing. Most of most cases of hearing loss, yes, it happens with age, but it's really due to excessive loud noises. Things like working around machinery, going to loud concerts or loud theater, and not protecting your hearing in those settings, like that isn't a great strategy while you're in your 30s, 40s, and 50s. So invest in some great hearing protection. There are really trendy ones now. I think loop earplugs are one where you can kind of control how much ambient noise you're having so you can still have conversations or still enjoy music. So really look into protecting your hearing because that's something that we don't think about until we're in our 70s and 80s when it's a little too late to reverse that damage. Other big risk factors, of course, being a woman, that that puts you at a higher risk of Alzheimer's disease and forms of dementia. And then carrying specific genes will put you at a higher risk. There are some genes that are highly deterministic, but most cases of Alzheimer's disease aren't related to these very deterministic genes. The most significant genetic risk factor is a gene called ApoE, which I'm sure a lot of listeners have heard about. If anyone has done testing through 23andMe, they often will report ApoE status, but a lot of people just kind of dismiss that as like, okay, yeah, what does that mean? I don't really know. But it really does change a lot about you and your risk. And while it's, quote, non-modifiable because we can't change your genes, there are a lot of things that we can do to combat that risk, whether it's addressing someone's cholesterol, changing their diet, thinking about exercise in a meaningful way. So I, in general, am a proponent of understanding that particular genetic risk in the right person with, of course, good counseling and someone who's highly motivated.
Yeah, it's so interesting to me, the hearing loss conversation. I literally just in the past week saw multiple, it's probably a study that came out recently and they're sharing it and it's popping up on social media as well as other news outlets. Is it more of a byproduct of the lack of stimulation for those auditory centers in the brain that they suspect is what puts someone at greater risk? Or is it more a reflection that individuals that are dealing with hearing loss are just less engaging with and socializing and around others? And that, because we know loneliness is a huge risk factor for neurocognitive decline. I'm just kind of thinking on my feet, like what would be the contributing factors to why hearing loss is a huge risk factor for developing neurocognitive issues?
It's both what you said. I don't think we could really sort out what the exact etiology is or how that pathophysiologically manifests into cognitive decline. But as you alluded to, hearing is processed in the part of the brain that Alzheimer's impacts. It's processed in the temporal lobe, and the brain is very use it or lose it. It likes to have stimulation and sensory input that can come from our eyes. Vision loss is another modifiable risk factor. It can come from our ears. So without that sensory input and stimulation, it's harder for those particular brain cells to maintain plasticity and health. So it's possible that that's why. But I think also what you said, if you can't hear, it's really hard to be cognitively engaged. You start being withdrawn and you aren't social, you aren't interacting, you aren't doing the hobbies that you once liked to do. And that makes a huge difference, even for people that are already experiencing cognitive decline. If they aren't social and able to interact, it really will impact their cognition.
And for benefits of listeners, let's talk about what neuroplasticity is, why it's so important, especially as we are aging. It's important to continue learning and to stimulate ourselves. And I will be the first person to say that when I don't want to be stimulated at all, I might, pull something up on my iPad and watch Netflix. But it's why I think pushing myself kind of intellectually is still really, really important. My husband's trying to convince me to work on learning a new language. And I'm like, maybe at some point. But with that being said, like whether it's Sudoku or crossword puzzles or, taking a class, it's just important to be continuously evolving and shifting.
Yeah, challenging your brain is key. Neuroplasticity is really referring to the brain's ability to adapt to changes over time. And this could mean increases in the way that different brain cells are connecting with each other, which could be building some sort of reinforcement or kind of an insurance policy against cognitive decline. But it could, and we didn't realize this was true until more recently. We thought, once brain cells have died, there was really no way of bringing them back. But it seems like that isn't quite true. In some cases, and usually in cases where someone isn't actually impacted by a neurodegenerative disease, there is a degree of also neuroregeneration, and that can happen from things like exercise specifically, which releases specific types of growth factors that can stimulate actually new brain cell growth, which is pretty cool to think about.
Yeah. Is it specific to like strength training or high intensity interval training or just zone two training, or is it just exercise in general?
A lot of it is related to cardio exercise and the optimal dose duration type of exercise we don't really know. And studies are so poorly designed in terms of telling us exactly what the right exercise is for the brain. But I'm a huge proponent of higher intensity interval training, alternating between high and low heart rates, because there's some interesting data that may support BDNF, which is this growth factor that helps the brain grow new cells.
It's like fertilizer for the brain. I mean, that's how I think about it. And in terms of other kind of lifestyle related pieces, talk to us about the importance of sleep for brain health in particular. I always say sleep is foundational, and I find that, I can tell on an intake form when I'm looking at a new client or patient, if they're not sleeping well, there's a huge downstream effect of poor quality sleep or, those nighttime arousals.
Disturbed sleep is a risk factor for various neurodegenerative diseases, and sleep is huge when we think about neurology and brain health. We learn a lot about someone's brain by the way that they sleep and their sleep habits. Um, it is, of course, what most people think of, like, how much are you sleeping? While that may be important, really thinking about the quality of someone's sleep is important. It's interesting because sleep is actually not recognized as a modifiable risk factor for neurodegenerative diseases, but it's hard to imagine that it isn't one. Um, Sleep stages are really important, and that really comes down to someone's sleep quality. Are they getting enough adequate REM sleep, which is when our body is or our brains are processing the things that happen during the day? Emotional processing happens then, memory consolidation happens then. If you aren't getting enough REM sleep, you aren't going to be able to remember what happened that day. And then deep sleep is believed to be this stage of sleep that is detoxifying for the brain. It's when the trash removal system or the glymphatic system is active, and it helps sweep away things like amyloid and tau proteins and alpha synuclein proteins that may contribute to various forms of neurodegenerative disease. So sleep stages are really, really important. But then thinking about, is someone snoring? Do they have sleep apnea? Are they acting out their dreams? Are they yelling, shouting? Like, all of those things also tell us about someone's risk. So, yeah, there's lots that we can unfold and talk about when it comes to sleep, because there's just so many facets to it that relate to how the brain's functioning.
Yeah, and I feel like so many middle-aged women have just kind of accepted that their sleep quality is diminished. These are people that may or may not be on hormonal replacement therapy, but just in general that they have a harder time falling asleep, a harder time staying asleep. They're getting up at night to urinate. There's just the sleep apnea piece, and we know from a conversation I had with Dr. Andrea Matsumura that, as we're losing progesterone, we get, that's a smooth muscle relaxant. And so it's much more common to see women, even with normal neck sizes. That used to be part of our cardiology conversation. For men, what size is your neck? Because if it was greater than 17 inches, they more than likely might have had trouble with sleep apnea, that women can present very differently with sleep apnea than men can. When we're talking about neurodegenerative diseases, Alzheimer's is probably the most well known, but I think we would be remiss if we didn't unpack what else is in that kind of constellation of disorders, largely because I don't think there's enough emphasis on other neurocognitive issues. I think Alzheimer's appropriately gets a lot of attention, but there are other things that women just need to be aware of.
Yeah, so neurodegenerative diseases is a very, very broad category of diseases. Yes, it includes Alzheimer's, and that's the most common form of dementia when we think about neurodegenerative diseases. I want to just mention that neurodegenerative diseases also encompasses diseases like multiple sclerosis. It encompasses diseases like ALS or Lou Gehrig's disease. So there are lots of different types of neurodegenerative diseases. When we think of neurocognitive neurodegenerative diseases, we really think about Alzheimer's, as I mentioned, which is the most common. There's Lewy body dementia or dementia with Lewy bodies. vascular dementia, and then some other more atypical forms of dementia like frontotemporal dementia, primary progressive aphasia. These things are less frequently seen, but they still exist and will present in different ways than these other diseases. And then it's my specialty because I'm actually a movement neurologist by training. We have the Parkinson's related diseases. So, Parkinson's, progressive supranuclear palsy, multisystem atrophy. Those are also other forms of neurodegenerative diseases that also can be associated with cognitive changes.
Yeah, it's so interesting. And I feel like neurology is really, at least in my clinical experience over the past 25 years, I always felt like neurology was so much less tangible, and therefore people in medicine would obviously defer to the neurologist, but it was so much less tangible for most of us. We're like, we understand the heart, we understand the kidneys, we don't understand as much about the brain. Therefore, it's this kind of nebulous organ that's very important. Do you feel that as a neurologist? I would imagine during your training, you might have experienced that where people are like, they have great reverence and respect for the brain, but don't fully understand or appreciate all of the complexities.
I was thinking about this because I'm also writing a book. And one question that I get asked all the time is about risk. And can you tell me exactly what my risk is? If I do XYZ thing, how much is that going to lower my risk? And unlike cardiology, where we have really good risk calculators and risk scores, for neurology, we don't have that. And it's impossible for someone to give you an estimate of your risk. There are so many surrogate markers that we can look at, and people have come up with risk scores, but on an individual level, they aren't all that great. And that's because, unlike cardiology and unlike a heart attack, which there are several factors that contribute to it, but there are limited factors that contribute to it. For brain health, there are so many variables that can contribute, and those variables have different weights based on someone and someone's biology. So it is, even as a neurologist, still very nebulous, and we still have so much to learn. I think it's fascinating. I could read about it all day, so I'm not intimidated by it, but um, that uncertainty really scares a lot of people away from the brain.
Yeah, I would have to agree with that. And I recall, back I was an ER nurse in inner city Baltimore, and so we saw a lot of unusual things. But I remember the neurologists would all come in with their little bags and they would, make determinations, do we have to send someone to surgery? Can we send them to the medical floor? And I used to always enjoy the conversations I had with them. But even then, they would say there's so much about the brain that we don't yet know. So it's kind of like the great vast beyond. Like, we will continue learning, we will continue being able to put things into practice. When I think about metabolic health, I think we would both agree that metabolic health is important systemically, not just for the heart, not just for the kidneys, but also for the brain. How does blood sugar regulation and insulin sensitivity directly affect the female brain? I think it's important to touch on this because, again, we go back to that fear piece. People are fearful of, we used to term it type 3 diabetes. Alzheimer's is type 3 diabetes. And so, how do you kind of provide a context for your patients about the importance of metabolic health?
Yeah. Um, we always hear this type 3 diabetes thing, and I have mixed feelings about I have mixed feelings about how it's being used. But regardless, the reason why a lot of people refer to Alzheimer's as type 3 diabetes is because insulin and glucose signaling change in the brain specifically. So our brain has insulin receptors, and insulin receptors help take up glucose, and glucose is really the brain's preferred source of fuel. So a lot of people think, oh, like glucose is bad, but like no, we actually brains really depend on glucose for lots of important processes. Over the course of different neurodegenerative diseases, Alzheimer's, Lewy body too, and we have particular PET scans, which we can actually look at the functioning of metabolism in the brain. We understand that there are changes in how the brain is handling glucose. So intrinsically, there are glucose metabolism changes that are occurring. These often relate to what's happening peripherally, but they don't always, but often they do. So, peripheral insulin resistance or type 2 diabetes is a risk factor for dementia, full stop. It is a risk factor probably for lots of different reasons or because of how it impacts the body in lots of different ways. One huge component of this is how it's related to visceral fat. And visceral fat is this fat around our organs that is very pro inflammatory and is linked to a higher risk of cerebral atrophy or brain shrinkage and then long term cognitive decline. And uh, our visceral adipose tissue does secrete a lot of inflammatory molecules into the blood. But again, insulin resistance impacts how rapidly our body is taking up forms of glucose, which again is, as I said before, one of the main ways that the brain is getting energy and using that energy for important neurocognitive processes. So if insulin signaling is off, the brain isn't getting the energy that it needs to complete important processes. And so when peripheral insulin signaling is off, central is also often off, although it's not always perfect in that way.
What are some of the common symptoms that women will share with you that make you suspect that they probably do not have optimal insulin regulation or blood sugar regulation?
I think one of the biggest ones that came to my mind immediately is feeling very fatigued and tired after they eat. Feeling like, oh, I got to take a nap, or my brain is just really does not function after I have a large meal, especially a carb-rich meal. That can be a telltale sign. And then I often see sleep disturbances in the middle of the night, early night awakenings with people who eat late at night. That doesn't necessarily mean you have insulin resistance. That can happen to anyone, but it could be a sign.
Do you use continuous glucose monitors in your practice or glucometers?
On a case by case basis, we do. I think continuous glucose monitors can be a helpful tool for some people. Too much data for other people is not great. So, I think one issue is overly optimizing health and how too much data can really set people in a bad thinking pattern. And I think that negative rumination really impacts brain health in a negative way. So I think data can be really, really useful for the right person, but I really try to stay away from overloading people with so much data because I don't want them to fixate on that. I want them to incorporate brain healthy strategies in a really accessible way that doesn't cause them stress and anxiety. Like, if I eat this cookie today, am I going to get dementia in 5 years? Like, I don't want them to think that way. So it's helpful for people who really have little insight into their dietary habits and how those may be impacting their hemoglobin A1C and fasting insulin and fasting glucose. So, if someone could benefit from that type of education, I think it's really, really helpful. And I've seen it go both ways.
Yeah, and I love that nuance to determining whether or not someone's appropriate for that type of intervention. I think that I agree with you wholeheartedly that we've gotten to a point where healthy people are wearing CGMs and gaining awareness, and that's great. But I think we've gotten to a point where I will have a patient say to me, or someone online will say, "Oh my God, I had this glucose spike." And I'm like, it is a normal physiologic response to see your blood sugar go up in response to a meal. I mean, to the degree that, you're sharing with me, that might be too high and you may need to adjust your macronutrients, but not to be at a point where someone is then paranoid to live their life. Like, I had a woman who was lovely. It was a competitive tennis player, and it caused her so much anxiety because she had such a physically demanding tennis match that she would see her glucose go up. And I was trying to explain to her why that was happening physiologically, but it was causing her so much anxiety that I said, when you are done with this 14 days, take it off and give yourself a break. And to your point, there are patients it's really appropriate for, and patients it would make them more anxious and unsettled, and therefore might actually contribute to worsening glucose variability just by the stress response.
Same for sleep and sleep tracking as well. Um, there are patients that come in and kind of share their aura data, and they're like, I got only 10% of REM sleep today. And the first thing I tell them is to throw the ring away. Like, just throw it away, because it is the reason why you aren't sleeping, because you're so fixated on what your score is going to be in the morning. And that is just not helpful.
Yeah, I think you have to look at it as it's like a prevailing overwhelm, like it's a theme. Like, did you wake up and feel great and your score looks terrible? Then pay attention to how you feel, or vice versa. You wake up and feel terrible and your score is okay. You're like, okay, maybe my night of sleep wasn't all that bad. When you're thinking about, like, let's think of three of your top things that you emphasize with your middle-aged patient that are important for brain health, that aren't a gadget. Let me be clear, we're not talking about you have to go buy something, but the things that you think are important and foundational for all middle-aged women that want to do everything they can to support a healthy brain.
I think movement and exercise is really the most important. And that is such a broad category. And as I alluded to before, we don't really know what the optimal type of exercise is, what the dose should be, how long you should exercise. But what I will say, and what isn't necessarily sexy, is that one huge risk factor for women is falls and frailty. We think a lot about obesity, but frailty and physical frailty due to low body weight, due to poor movement patterns, inability to move your muscles and joints in full ranges of motion, does contribute to falls later, and falls are a risk factor. And that's not something that we think about in middle age at all. We think about, how to train so that we could do a pull up. We aren't thinking about, like, how do we prevent ourselves from potentially breaking a hip later? But that really does matter for long term brain health. So I always encourage women to think about, yes, do your strength training, yes, do your cardio, but make sure that you have the foundation of your movement right. And if you have or are getting frequent injuries, there's a reason for that. So look into that a little bit more deeply, because it could be saying something about your stability strategy or your movement patterns that later in life may come back to haunt you.
Yeah, it's so interesting. I recall sharing with someone that I remember I had patients that were 50 years old that couldn't get off a bedside toilet, a commode. And I think what many people don't realize is that, right now we're maybe not thinking about what are the things that are to come, but the loss of muscle mass, skeletal muscle mass, plus frailty is what leads to falls and a lack of independence. So I always say, like, if you're not worried about the falls, be thinking about being dependent on another person or having to live in assisted living or nursing home. And those are the things, those are the bigger things that I think many people that are certainly in my age range are probably not thinking of. Like, we're so privileged that we've been able to see patients. And it was interesting. I think I saw it was there was a Hollywood actor who's probably late 70s, and I saw like a video of him walking across the street. And I said to my husband, he looks so frail. Like, he's a healthy weight, but he's so frail that I'm concerned if that person tripped, you think about breaking a bone, but it's like, oh, this is someone who's really at risk for this frailty. Frailty leads to falls. Falls lead to this loss of independence. And I'm sure you could speak better than anyone that a loss of independence, loneliness, how destructive that is to our brains. Can you speak to that in terms of when you're working with your patients that are perhaps a little bit older, the ones that maybe their spouse has died or they don't have local family, they're not engaging with individuals, how much loneliness impacts our brain health?
Yeah, I can actually share a story that came up a couple of weeks ago from a patient who moved her mom. Her mom was living in Florida alone. Family was not anywhere nearby. Mom was diagnosed with Alzheimer's disease, and it seemed to be getting worse. And so moved mom into memory care, and is blown away by how great her mom is doing, because she has a structured schedule where she's doing activities with the community. She has people to talk to. That has improved her cognition. It is really humbling to have that realization that your environment, who you're interacting with, does impact your current cognitive function. And of course, if you can think about what it could do acutely, imagine what effect it has over the long haul. But just going back to this loss of independence and falls, the other thing is we hear it time and time again in our practice. My loved one was fine, and then they sustained a fall, and their cognition really started to go downhill after that. Falls can result in head injuries, and head injuries are another big risk factor for dementia. So, just thinking about really how multifaceted falls are. So, I think women should think about it in midlife because that's when our fall risk starts. It's about working on your balance, movement capacity, and of course, muscle mass now so that later in life we can maintain that independence.
Yeah, so important without question. I have some rapid fire. This is like a new subsect of the podcast. Rapid fire questions. Most underrated risk factor for Alzheimer's in women.
Like, I honestly think falls and frailty. Like, I think what we were just saying, I think frailty, physical frailty, we see this so commonly in our practice that women who are in their 40s are on the verge of sarcopenia, which is age-related muscle loss. And our muscle mass will only decline with age. So seeing that in midlife is really, really a red flag. And although it is not spoken about in terms of big major risk factors, it is one. So I really think fall risk, sarcopenia, those are things that are specific to women more so than men.
Absolutely. Sleep issues that do the most damage to memory over time.
Sleep, can we say sleep habits that do the most damage to memory over time? There's probably two. It's hard for me to pick one. I think rumination at night is a huge problem and something that a lot of women specifically fear treatment around, or don't necessarily acknowledge the root cause of the rumination. I have seen a lot of very high functioning people kind of bottle up a lot of their stress to nighttime, and that trickles down into lots of negative effects. But really getting to the root of your rumination and seeing if it warrants some sort of treatment can be really, really useful. I've seen really great results with people who've started even low doses of SSRIs at bedtime. That has been life changing for a lot of our patients. So don't be afraid of taking a medication if you need a medication like that. There is no evidence that that is going to harm your long-term brain health. In fact, there's maybe some evidence that it may help your long-term brain health. So I always encourage really seeking treatment if there's some sort of rumination. Also, cognitive behavioral therapy could be really helpful in those situations too if you don't want to go down the pharmacological route. And then the other habit is going to your medicine cabinet for over-the-counter drugs to help you with sleep. Things like Benadryl, Tylenol PM, Unisum, all of those things will definitely put you to sleep in the short term, but long term will probably impact cognitive function. So try to stay away from those and really get to the bottom of your issues if you aren't sleeping.
Oh, I love that. It's so thoughtful. It's interesting. I did a presentation in November talking about lifestyle and middle age, and cognitive behavioral therapy, the insomnia type, is incredibly effective. Like, I was shocked. The research was so solid, and maybe I had poo-pooed it in my brain until I actually read the research, and I was like, huh, that's actually really, really effective. So what you said is completely in alignment with what I learned from the research. And it's interesting. I remember when I was still working for that very large cardiology group, one of the things we struggled with was trying to find psychiatrists that were taking patients. So I don't know if it's a problem in New York, but it was certainly a big issue in Northern Virginia where I practiced. And it was impossible to find people that were, and this is not a knock on psychiatrists. I'm just saying, like, observationally, I'm curious if you see the same issues. Really hard to get patients in, really hard to find people that were still taking insurance. Do you find that that is a systemic wide issue? Is that also concurrently challenging where you are in New York?
Yes, and I'm not bashing psychiatrists. It's equally hard to get into a cognitive neurologist. I know the waiting list is 12 to 6 months for most of these larger academic centers, which just is mind-boggling. There's really so much need for mental health support and neurological support, and there aren't enough specialists that are trained in it to administer all of the care that's needed. So, yes, without a doubt.
Yeah. Last question. One early brain symptom in menopause that's common but reversible.
Word finding difficulty. Having a word at the tip of your tongue, very, very common and terrifying. I think probably the most terrifying cognitive symptom that women will come to me with, but it is reversible. Um, a lot of women, as I said before, when they start hormones, the cognitive benefits that they feel, a lot of that word finding difficulty gets better. It doesn't always get better. It can get worse with age, but it can be reversible.
And is it just to reassure people, having trouble finding a word 1 or 2 days a week is different than persistent, bothersome symptoms? Because I know, and I'm saying this to you just to be transparent with listeners, it's that sleep piece. If I'm jet lagged, not getting enough sleep, most recently it was at a medical conference I spoke at, and I was like, it's 3 hours time difference, didn't get enough sleep 3 nights in a row. By the third day, after like the third podcast, I was like, holy cow. Thankfully, I got through it, but I was very cognizant of I have to work a little harder to find like specific words. And then as soon as I got home, I was fine.
Yes. So I should specify on the word finding difficulty. Yes, having this, a couple of times a week is probably not a big deal. What may be a little bit more concerning is if you're calling words by the wrong name, or if you are using excessive vocabulary because you can't find the word regularly to describe that word. That could be a sign of something more significant.
Yeah. Well, I've so loved this conversation. Thank you for carving time out of your very busy schedule and the holidays to meet with me. Please let listeners know how to connect with you outside of the podcast, how to learn more about your work or work with you directly.
So, the best way to get more information from me is following me on Instagram. I'm pretty active on that platform. So, it's at Dr. Kellyann Niotis. And then I have a website, which is www.drkellyanniotis.com, and soon to have a practice website, which will launch in the new year, which is preventive-neuro.com.
Amazing. Thank you again for your time. Hey, if you like this video, you guys are going to love this video, and I'll see you there.
The conversation I'd love to have with every 35-year-old woman is that once 40 hits, your ovaries are going to be done, and they're going to slowly, it's not like it's done overnight, they're going to slowly decline. It's going to take 10 to 15 years for these ovaries to be out. But you literally have an organ that is done doing its job. It'd be like if your heart was like, hey, I'm done. I'm just going to slowly like this. I don't understand why we don't talk about this.
Right.